Hello everyone. My name is Dragana Rakasevic. I come from University of Belgrade, Department of Periodontology. And before I start with my presentation, I would like to say that we 3 years ago started the project with botiss, where we had to compare new material at that time, collagen matrix, Macoderm, with the connective tissue graft and Emdogain in the treatment of multiple gingival recession using tunnel technique. So this was a long-term study, and here I would like to show you our results which we achieved after using collagen matrix and connective tissue graft and tunnel technique in the treatment of multiple gingival recession. So this presentation will contain introduction, and we will focus on gingival recession defects, their diagnosis and prognosis, and surgical procedure for root coverage. So we will talk a little about aim of the study, materials and methods, expected and gain result, and after that we will have conclusion. During all the time, you will be able to take a look at our results followed by photos, and I will discuss them later in materials and results. So to start with our presentation. As you know, mucogingival therapy is a general term used to describe periodontal treatment that involves correction on defects in morphology, position, and amount of soft tissue and underlying bone support around teeth and implants. Most precisely, it is defined as a surgical procedure performed to prevent or correct anatomic, traumatic, or disease-induced defects in gingiva, alveolar mucosa, or bone. So according to these definitions, mucogingival plastic surgery and therapy includes various soft and hard tissue procedures. So aim of the mucogingival plastic surgery is not only to reconstruct and correct mucogingival defects on teeth and implants, but also to correct the mucogingival anomaly. Moreover, the aim of mucogingival plastic surgery is to reconstruct of interdental papilla and to achieve gingival augmentation and root coverage. So, gingival recession is one of the most complex and attractive problems in periodontology. It presents one of main indications for periodontal plastic surgery, and also we could say that it is a social economic problem with high percentage of prevalence. It is defined as apical migration of marginal gingiva resulting in root exposure. Also, it is associated with improper plaque control, tooth hypersensitivity, root caries and cervical abrasion, and also could induce periodontal disease progressions. Different etiological factors as well as predisposing anatomic factors are associated with gingival recession. It is multifactor etiology, usually connected with thin gingival biotype, insufficient attached gingiva, buccal bone dehiscence, genetic, direct trauma associated with malocclusion, traumatic occlusion, also inappropriate orthodontic move of teeth. So on your right side in this picture, you can see one of those mucogingival recessions, and that could be insufficient attached gingiva, and also could be a buccal bone dehiscence. In this picture, one of cause this localized gingival recession also could be insufficient keratinized tissue width and also insufficient attached gingiva, but also it could be a malpositioning of the teeth. So a lot of classification of gingival recession are described in literature, and mostly we use a Miller classification. So according to Miller classification 1, recession does not extend to mucogingival junction. So here, complete root coverage is achievable about 100%. Miller class 2 recession extends to or beyond the mucogingival junction with no periodontal attachment loss. So also here, complete root coverage is achievable also about 100%. Miller class 3 classification, where recession extends to or beyond the mucogingival junction with periodontal attachment loss in interdental area. So here is only partial root coverage possible, and it is about 50 to 70%. And finally, Miller class 4, where recession extends to or beyond the mucogingival junction with third bone, a soft tissue loss in the dental area, and dermal positioning of teeth. Usually it is connected with periodontal disease, and here root coverage is unpredictable and only could achieve 10%. So one more classification of gingival recession could divide into the both single and multiple gingival recession defects. Indication for the treatment of gingival recession defect is aesthetic reason, which also present main indication in patient chief complaint, especially if we talk about high aesthetic demand patient. Also, we need to reduce the root hypersensitivity and to try to create or augment the keratinized tissue. Therefore, the goal of periodontoplastic reconstruction is complete and stable root coverage with achieved tissue regeneration. As you know, the presence of thin gingival biotype is considered to be one of the most relevant anatomic factors related to gingival recession. So the aim of root coverage is not only to achieve complete and stable root coverage outcomes, but also to increase keratinized tissue width and gingival thickness. So before we go further and decide what treatment we would perform, the attention should be taken to the following plan and patient's criteria. So evaluation of patient's ecological profile as well as risk factors is really important, as that could have major influence on post-surgical outcomes. So please take a look which patient psychological profiles and risk factors are, because it could definitely influence your future plan. So now we can go on. A number of procedures have been proposed of treatment of gingival recession, and that includes a pre-gingival graft, but only performed in mandibula. Then we have lateral position flap and its modification, and coronal advanced flap with the application of different grafts and materials. So management of multiple gingival recession presents a challenge in the treatment of gingival recession. It becomes more complicated and wound healing may be compromised by a variety of factors. First of all, the vascular surface is more extensive, producing limited blood supply. Then differences in recession depth and width, as well as teeth alignment, are also needed to be taken into consideration in the management of multiple gingival recession. Also, some anatomical characteristics such as thin gingival biotype, insufficient keratinized tissue width, and root prominence as well as root proximity also influence the choice of surgical treatment. In comparison with localized gingival recession, all of these factors are too complicated and could influence result outcomes and our future treatment plan. Because of that, several different techniques have been tested and described in treatment of multiple gingival recession, and one of those is coronally advanced flap, usually performed and described by Tukeli. So here in the few photos you will be able to see how it was performed, how incisions look like, and after that you will see the final outcomes. So let's pay attention to this slide and what basic clinical factors for successful root coverage outcomes depend on. They definitely depend on histocompatibility of exposed root surface, vascularization, suturing, stable wound during healing period. But also it's really important to be skillful during surgical procedure and to create adequate design of the flap if you want to get successful root coverage. So if you take a look at that, we can go on. The second one, also most usually performed technique, is modified coronally advanced tunnel technique. And this technique has been suggested as minimal invasive, safe, and predictable technique. Also, this technique allows extensive coronally positioning of the flap with complete graft coverage. So according to the most recent systematic reviews, predictable root coverage is possible in both single as well as multiple teeth recession defects by using connective tissue graft procedure, providing the success of the root coverage outcomes. It also presents the gold standard, and it was first introduced by Edel in 1975. So now you can see the way of harvesting graft from the palate, the way of how incision looks like, and how graft looks like. So we can go further. And some benefits of connective tissue grafts is it presents a gold standard in gingival surgery are different. We could say that it is really powerful augmentation graft which produce fast biointegration. Also, it could achieve adequate cover of the root surface with extension of detached gingiva. Also, it could gain and spread the keratinized tissue and change tissue biotype. In available literature, connective tissue graft has shown successful root coverage in the anterior side of both mandibula and maxilla using tunnel technique. It is also an adequate choice for papilla augmentation with high rates of success. So now you will be able to see in these pictures the way or how papilla augmentation was performed. And this is the final outcomes. Although connective tissue graft is shown to be associated with a high success rate, some limitations need to be taken in consideration. First of all, we do not have adequate amount of soft tissue for augmentation, especially if we want to cover multiple gingival recession defects. Then, we need second surgical wound, which increase complication levels and patient morbidity and produce pain. So clinicians are looking for substitute graft or material that would decrease invasiveness, providing the root coverage of both single and more specifically multiple gingival recession within single surgical intervention, accompanied by keratinized tissue augmentation and clinical attachment level gain. So because of that, different biomaterials have been developed and tested in various in vitro, in vivo, and clinical study and divided into few groups. First group could be passive regeneration, which includes a cellular dermal matrix, collagen matrix, and different biomembranes, resorbable and non-resorbable. Next group could be biomimetics, which includes enamel the matrix derivative names as endogame. And the last one group, active regeneration, mostly include some growing factors and palatal-rich fibrin membrane. So experimental clinical studies have presented the 3D soft tissue collagen matrix derived from the porcine dermis intended for the soft tissue regenerative therapy. It is pure porcine collagen matrix consisting of the collagen 1, collagen 3, and elastin without artificial cross-link or chemical processing. It supports revascularization, produces fast soft tissue integration, and also shows high biocompatibility. So it could be a valid alternative for patient of connective tissue. Some advantages of collagen matrix would be in the second surgical avoidance, thus reducing postoperative complication and discomfort. Furthermore, no limitation of amount of graft are needed. It is indicated in various surgical procedures for soft tissue augmentation. However, it is highly recommended in the treatment of gingival recession. So because of that, there are few studies try to compare this material with the gold standard connective tissue graft. And my colleague and I have done the similar design study to these above mentioned studies. And now I would present you the design of our study with unpublished results. Since this is unpublished result, I could only give you described and approximated results. So we set up a hypothesis and have some questions about this material. and I will discuss these later. The aim of the study was to compare clinical outcomes of collagen matrix and connective tissue graft in the combination with tunnel technique in the treatment of multiple gingival recession. We also wanted to evaluate the mean complete root coverage and to assess keratinized tissue width and gingival thickness gain. The subjects included in the study were the patients of Department of Periodontology School of Dental Medicine. The study was designed as a split-mouth prospective randomized controlled clinical trials, and all patients enrolled in the study had 2 or more multiple gingival recession in both sides of maxilla or mandibula. In total, 20 patients were recruited for this study. If they wanted to be involved into the study, they should meet inclusion criteria, and in these 2 tables you can see what inclusion and exclusion criteria were. The following clinical parameters were recorded using manual probe, periodontal probe, and we measured gingival recession depth, which is measured at the mid-buccal aspect of the tooth from the cinema-enamel junction to most apical point of the gingival margin. Then we measure gingival recession width and also keratinized tissue width, which is also measured as a distance between the edge of gingival margin and mucogingival junction. After that, we measure gingival thickness, measured at the mid-buccal aspect of the treated tooth on the long axis 1.5 mm apically from the gingival margin using needle for endodontics treatment with silicone marker after application of local anesthesia. Clinical evaluation of postoperative healing was estimated by mean of the healing indices registered at first, second, and third week postoperatively. Complete root coverage as well as mean root coverage calculated by following formula were also evaluated. Examination of all parameters were done at baseline 6 and 12 months after the treatment. Study was divided into test and control group. The test group was treated with porcine collagen matrix, while the control group received the connective tissue graft. Modified coronally advanced tunnel technique was performed in both groups. Surgical procedure was performed on 20 patients who met all inclusion criteria. So before the surgical procedure, all patients underwent professional teeth cleaning and received instruction of proper oral hygiene measures. I would like to mark that plaque and gingival index had to be less than 20% in order to perform the surgical treatment. So now, through the cases, you will be able to see how we perform the surgical procedure, and I will describe it. So to start, after local anesthesia administration, root surfaces in a region between the bottom and the sulcus of the cinema-enamel junction were scaled and planed by ultrasonic device and hand instruments. I would like also to mark that no additional chemical treatment of the root surface was done during the surgery. Sulcar incisions were made in the recession area of the teeth without damaging the interdental papilla. Mucoperiosteal dissection were made using the periosteal elevator, creating a deep pouch between the mucogingival junction, beyond the mucogingival junction. According to this, the mucoperiosteal flap could be moved coronally without tension. So test sites were treated by using a collagen matrix prepared according to manufacturer's instruction. Collagen matrix was sized and shaped to the treated area and hydrated in saline solution for at least 15 but not longer than 30 minutes. It was positioned at the level of cinema-enamel junction and tightened for the teeth to trigger forming a thick blood clot between the teeth and collagen matrix. A separate single suture per tooth with a 5.0 resorbable suture were used to stabilize the dermal matrix. The tunnel flap was positioned coronally about the cinema-enamel junction to cover matrix completely and suture with double sling suture technique using 5.0 non-resorbable polypropylene suture. So I will keep showing you the ways to perform the surgery, and here we use tunnel technique and applied collagen matrix, suture it, and this is one more case after performing a tunnel technique and collagen matrix. So control site was treated with the connective tissue graft, which was harvested from the palate by single incision technique. It was also positioned at the level of cinemal-animal junction and stabilized with also 5.0 resorbable suture. The care was taken to get a similar thickness of the connective tissue graft to the thickness of collagen matrix. So tunnel was positioned also, and suture being the same in the both as a test and control group. Postoperatively, patients were prescribed antibiotics and painkillers. Also, they instruct to rinse with the 0.12 chlorhexidine solution twice a day and to avoid mechanical trauma at the surgical site. The sutures were removed after 14 days. Postoperative care include reinforcement of oral hygiene measures and mechanical plaque removal whenever necessary. All data were analyzed using SPSS 20 statistical software, and all p-values less than 0.05 were considered significant. At the beginning of the study, we set up hypotheses and also expected result in a towards significant improvement of clinical parameters after using collagen matrix compared to connective tissue graft. To the presenting of the result, the study will give some answer regarding validity of collagen matrix application in regenerative periodontal treatment in humans. Before I show you our results, I would like to mention that in recent years, the modified coronally advanced flap and tunnel technique in conjunction with connective tissue graft or either substitute graft or material have been effectively applied in the treatment of multiple gingival recession. Also, tunnel technique is one of the less documented surgical procedures for the treatment of multiple gingival recession when the collagen matrix was applied. So, the aim of our study was to estimate the clinical efficiency and stability of collagen matrix in comparison with connective tissue graft, which presented a gold standard as the most documented treatment procedure in gingival recession covering. So now, I will show you our result. In our study, 20 patients with split mouth gingival recession, almost equal proportional distribution female and male, met inclusion criteria and got both treatment modality, connective tissue graft, and collagen matrix equally. I want to highlight that adverse events such matrix exposure or loss, allergical reaction, or infection related with the both treatment concepts were not recorded. On your right side, you can see a bar chart, and this bar chart shows small numbers of smokers were involved in the study. So, as this is a small incomparable number of the smoker, we cannot conclude if the smoking has influence on positive or negative result outcome of covering gingival recession. So let's go further with the slides. Around 80%, as you can see, gingival recession of Miller class 1 and Miller class 2 were treated in maxilla. Mostly recession were localized at premolars and canines. So almost equal number of gingival recession were treated with collagen matrix and connective tissue graft. And there were no statistic differences between treated defects and treatment modalities. And what about healing index? Postoperative healing was uneventful for the both examined groups. As we can see in the east line graph, the healing index scores were statistically significant in the test group compared with the control group after first and second week postoperatively. So on your right side, you can see what healing was like in collagen and also in connective tissue group. So now we could talk about gingival recession defects and its coverage. So no statistically significant difference were observed between control and test groups at baseline in terms of all parameters. There were intergroup statistically significant improvement in gingival recession depth and gingival recession width at 6 and 12 months. However, there were no statistical difference between both groups in these parameters during follow-up periods. Our results regarding reduction are comparable with the results of other studies, where evaluate the clinical efficiency of collagen metrics in the treatment of multiple gingival recession using tunnel technique after 12 months. We also achieved reduction of nearly 2 millimeters of gingival recession as it obtained in another study. The results of our study are comparable to those presented by Beggersmuth and colleagues. They performed similar methodological and design study as we did, and equal reduction in gingival recession gain in both studies. So now we will see the result outcomes followed by picture, and I will discuss it. Here's one case after application collagen matrix, and here you can see the results after 6 months. As you can see, we couldn't achieve complete root coverage, but we definitely changed tissue biotype. We gained certain amount of gingival thickness. And this is result after 12 months. As you can see, we achieved completely root coverage. We gain certain amount of keratinized tissue width and change thickness of gingival. And one more case. On your left side in picture, the cause of this gingival recession could be traumatic occlusion. So you can send me your opinion about this. And on your right side, this picture shows final outcomes after 1 year, and as you can see, we completely root coverage after 12 months. So this is the next case after application of connective tissue graft. This is result after 6 months, and this is result after 12 months. I need to apologize for the feeling of this lady. We asked her many times to change it, but as you can see, she hasn't done it yet. So just to discuss a little about these pictures, as you can see, we achieved a completely root coverage after 12 months, and we definitely changed tissue biotype. So we definitely proved that as from the beginning, connective tissue graft is very powerful augmentation material. And one more case, multiple gingival recession before, and this is 1 year after the surgery. So we go on. Another important issue that should be discussed in the treatment of multiple gingival recession is change in keratinized tissue width and gingival thickness. So those are our next question, which we set in our hypothesis, and now we'll discuss about it. First, I need to mention that we achieved certain result of the change in keratinized tissue width, and 6 months after treatment in collagen group, statistically significant improvement was gained in keratinized tissue width. However, there were no statistically significant difference between both groups at a period of 12 months. Another study also achieved increase in keratinized tissue width at 12 months, as we did in our study. And why it is important? The gradual change of keratinized tissue width through the period of 12 months when the collagen matrix were applied could be interesting due to the fact that it demonstrates a tendency of the progressive increase of keratinized tissue width over time. So, as it is known, achievement of a certain amount of keratinized tissue width, but also attached gingiva is necessary to maintenance of integrity of dental gingival junction. So let's go on. Different factors also could influence our results, and one of these may be the suturing technique and fixation of graft and material. So there is still question which technique performance could be used to achieve better result in the healing and to influence the keratinized tissue width increase positively. Now we'll talk little about gingival thickness. Statistically significant increase occurred in the both group in gingival thickness at 12 months compared with baseline value, as you can also see in this graph. But interestingly, the increase in gingival thickness was significantly better in collagen group. At 12 months, the mean gingival thickness demonstrated an increase of almost 1 millimeter in a test group, and this result is contrary to other researchers' results who got increase in gingival thickness in the favor of connective tissue graft after 12 months. Also, this is one of the results of our study, and also you can see here how it changed gingival thickness. This is one also more interesting study where compared the cellular dermal matrix with the connective tissue graft in the treatment of multiple gingival recession, also after using tunnel technique. The increase in gingival thickness was lower when compared to the present study. So one of the reasons could be the structure of a cellular dermal matrix, which is different from the structure of a collagen matrix. Now we will talk a little about complete root coverage and mean root coverage. So complete root coverage in both examined group were insignificant during the follow-up periods. As you can see in the first pie chart, the complete root coverage rate of all recession was similar in both groups. However, as you can see, when applied the connective tissue graft gained slightly more root coverage than after applying collagen matrix. Similarly, on your left side you can see a bar which shows mean root coverage, and mean root coverage also was slightly better in control group. So, to best to our knowledge, only 2 randomized control trials compared the collagen matrix application with the connective tissue graft after using tunnel technique and after also period of 12 months. So one of those studies achieved better results in a mean of root coverage in a favor of connective tissue graft compared with collagen matrix, which is definitely different for the result of our study. And one of the reasons also could be the period of follow-ups. As you can see in this study, they followed their parameters after 6 months, and we followed and got results after 12 months. So now we will see results after applying connective tissue graft and tunnel techniques. And some of these pictures you could see in materials. So I'll discuss them. This is multiple gingival recession defects, and this is result after 12 months. As you can see, definitely connective tissue graft, as I mentioned before, is very powerful augmentation material. We got change in tissue biotype, we gain thickness of the gingiva, and we complete the root coverage. And this is also one more cases. And what about collagen matrix and tunnel technique? So on your first picture, you can see also multiple gingival recession and thin gingival biotype. And as you can see on your right side, we couldn't achieve complete root coverage after the period of 12 months. However, we could achieve changes in thickness of gingiva. One more case, multiple gingival recession before. And this is 6 months after the treatment. As you can see, we achieved completely root coverage and gained certain amount of keratinized tissue width and also gain gingival thickness. So this is the result after 12 months. And you can see in this premolar, we have small recession. I think it's about 0.5 millimeters. And one reason could be, for example, traumatic occlusion or mechanical brush. So send me your opinion also about this. But we definitely change the tissue biotype. This is very interesting case. Also, after application of collagen matrix and tunnel technique. And this is result after 1 year. So as you can see the picture down, first of all, we completely root coverage. Then we change tissue biotype. We gain certain amount of keratinized tissue width and thickness of gingiva. And one more case before. This is 12 months after the therapy, but this is result after 24 months. As we can see, we got stable clinical outcomes and complete root coverage also after 2 years. So I will show you one more case in mandibular, and here is result after 6 months. This is result after 12 months and final result after 2 years. As you can see in this picture, we definitely except we covered a small gingival recession, we gained certain amount of keratinized tissue width and also changed gingival thicknesses. So there is one more question to need to be answered, and that is, will this type of the treatment be associated with decrease in patient morbidity and discomfort? So as you can see on this first pie chart, after using just single surgical procedure followed by application collagen matrix, was less painful in comparison with the application of connective tissue graft. So if you take a look at these slides, I will go on. And before I give the answer on this question, which also could be one of conclusions, I would like to go back to the treatment plan and which proper clinician choice would be adequate in the treatment of gingival recessions. So I joined few graphs in this one graph, and this graph refers to right decision which technique should be used regarding the criteria. So look at this graph and I will explain it. So first of all, you should look your attached and keratinized tissue and gingiva. So is it functional or not? If then you choose technique. So then you look at tissue biotype. You should look if it is thick or thin. So if it is thin biotype, you should apply connective tissue graft, collagen matrix, or a cellular dermal matrix. And which materials or grafts you performed or like, that depends also on the cost, price, but also how skilled and skillful you are. Then you should look at morphology of interdental papilla. So I write here negative and positive interdental papilla. Negative could be the papilla, which is high and narrow, and positive is wide interdental papilla. So, if you have a negative interdental papilla with a certain amount of keratinized tissue with about 2 or more millimeters, then choose corneally advanced flap open technique. But if you have positive wide interdental papilla with keratinized tissue with 2 or less than 2 millimeters, then choose tunnel technique. And why I'm telling you this? Now I will show you one more case, and here the rule were not followed. The young male came into my office a few weeks ago. He had multiple gingival recession in both side in mandibula and maxilla. Etiological of the teeth recession could be improper and aggressive teeth brushing, also could be improper position or conation of the roots, but also could be open bite. It's also multifactor etiology. And he had thin gingival biotype, and I should change it. And the reason why I did that, because that guy is prepared for the prosthetic. He wants veneers and crowns, so this is pre-prosthetic preparation of the gingiva. So I would like to also say that this is very high aesthetic demand patient with and also really frightened. So here I choose tunnel technique with applying collagen matrix, and to say that this guy couldn't come to recalls after surgery since he went to his home to another country. So this is the result after just 3 weeks. As you can see, the suture were broken and tissue returned and at almost same position as it was at beginnings. I changed gingival biotype. I gained certain amount of gingival thickness, but I couldn't achieve complete root coverage. And one of the reasons could be tension, but also patient impatience to see the result. So I please you to follow the rules and to evaluate the psychological profile of your patient before start any treatment, so you won't get results like mine. And finally, I could give some conclusion with the limitation of our study. Since there were no differences between connective tissue graft and collagen matrix in the treatment of multiple gingival recession after using tunnel technique, and also we got a certain amount of keratinized tissue width and gingival thickness, we could say that porcine dermal collagen matrix could be used as a substitute of connective tissue graft in the treatment of multiple gingival recession. So that would be that for our presentation. So I don't know, as I can see, we are running out of the time. And I see 2 questions. What are the results on mandibula? As I mentioned, we had just 20%, and okay. I just answered this question. The results in mandibula was great. We changed gingival thickness, and we also got coverage of root surface after using collagen membrane. But as you see that we are running out of time, and also we have some questions. I would glad if you send me questions with your emails, or you can email me on my email address. So once more, thank you for your attention.